Good evening, everyone. So welcome you all for this penultimate session of today's program. So we have with us Dr. Aishwarya Annamalai, who is an assistant professor from Coimbatore. She is going to speak to us on an interesting topic. There's a focus in clinical nephrology. As all of us know, POCUS is a valuable adjunct, just not to the diagnosis, but to the physical examination as well. And POCUS is something in nephrology and beyond nephrology. So we'll hear to Dr. Aishwarya for the next 20 minutes as to what the POCUS can help us in clinical nephrology. Over to you, Aishwarya.
Thank you, ma'am. So good evening to our respected professors, senior colleagues and friends. At the outset, I'd like to thank our scientific committee for giving me this wonderful opportunity. For the next few minutes, I'll be discussing point-of-care ultrasound in clinical nephrology, a contemporary examination tool that is now considered a mandatory skill for clinicians in various specialties. So POCUS is a clinician-performed bedside ultrasound that's used to answer focus questions. It helps us to narrow down the differentials, to confirm a suspected diagnosis, and to guide a procedure. So how does POCUS differ from the comprehensive referral ultrasound? POCUS is often used to answer binary yes or no questions at the bedside. For example, does this patient with AKI have hydronephrosis or not? Comprehensive referral ultrasound, on the other hand, involves complete assessment of the anatomic region of interest. POCUS is evolving as an important component of physical examination and is now recognized as the fifth pillar of bedside assessment. So let's get to some basics of ultrasound for the benefit of our postgraduates. So to choose the right probe, we need to know that high-frequency probes generally have a short penetration with good resolution. Low-frequency probes have deeper penetration with low resolution. So the linear or the vascular probes are high-frequency probes that are meant to visualize shallow structures less than 8 centimeter. The curvilinear probe is a low-frequency probe that is meant for deep structures. The phased array or the cardiac probe is also a low-frequency probe, but it has got a narrow footprint so that it can be placed in the intercostal space. We have the all-in-one handheld ultrasound probes that can be just connected to a smartphone, and with a click of a switch, this probe can be used to simulate all the three modes. The concept of image interpretation. For all practical application, the orientation marker is on the left side of the screen. So for longitudinal view, the superior aspect of the image will be on the left side of the screen and the inferior on the right. For transverse view, the probe marker should be oriented to the patient's right. So the right side of the image will be on the left side of the screen and vice versa. There are 4 cardinal transducer movements: sliding, rotation, tilting, and rocking. There are 2 types of POCUS. Basic POCUS involves B mode, M mode, and the color Doppler mode. Advanced POCUS involves spectral Doppler. It has got 2 variants, the pulsed wave Doppler and the continuous wave Doppler. So this is an example of the various ultrasound modes. So let's get to the topic proper. This begins with a basic question: which sonographic assessment can the nephrologist perform? As a physical examination performed by us is not very different from that of general physicians, we should be able to perform most of the ultrasound assessment that's relevant to internal medicine. So this picture is self-explanatory in that it says that POCUS in nephrology is beyond just the kidney ultrasound. It has a wide variety of application in clinical nephrology, like assessing the cause of AKI at the bedside, to rule out hydronephrosis, to assess the hemodynamic and fluid status of patients using lung and cardiac ultrasound, to guide therapeutic procedures like renal biopsy and placement of dialysis catheter, and for AV fistula mapping. So each of this topic is an extensive topic by itself. So as we have time constraints, I'll restrict my talk to the basics of kidney ultrasound and to POCUS hemodynamic assessment. So let's begin with the normal renal ultrasound. So we know that the cortex is iso or hypoechoic to the surrounding liver and the spleen echotexture. The medullary pyramids are anechoic. The collecting system is not normally visualized unless distended because it's obscured by the renal sinus fat. As we look at the kidney, we should quickly run through this checklist, which is abbreviated as seconds, where S stands for size, E for echogenicity, C for collecting system, O for outline, where we look for any mass disrupting the renal outline. N stands for any notable lesions like cysts or stones, D for Doppler assessment of the vessels, and S for surroundings. The commonest indication of renal POCUS is exclusion of urinary tract obstruction at the bedside. So let's get to the role of POCUS in performing renal biopsy. This is an interesting paper from Canada where the authors looked at the impact of a biopsy needle direction on specimen adequacy and risk of bleeding. They describe what's called as an angle of attack, which is obtained by drawing a line tangential to the point of entry of the needle into the kidney. So if we perform a biopsy at an angle of 40 degree, the needle is medulla avoiding, whereas at an angle of 80 degree, there are more chances of entering the medulla and prone for bleeding complication. So they concluded that by performing a biopsy directed at the poles and by angling the needle to 60 degree, there is a less chance of entry into the medulla compared to the perpendicular approach. So the perinephric hematoma, which happens after a kidney biopsy, gives a kidney-on-kidney appearance. If there's a bleeding into the collecting system, we get to see the bunch of grapes appearance. For the next few minutes, we'll discuss POCUS hemodynamic assessment. The true perfusion pressure of an organ is determined by the precapillary arteriolar pressure and the postcapillary venular pressure. So any small increase in venous pressure can have a significant impact on organ perfusion. It is unfortunate that venous assessment is still the missing piece of the hemodynamic puzzle. There are many deleterious systemic consequences of venous congestion, ranging from cerebral edema, delirium, myocardial edema, conduction disturbance, to congestive nephropathy and low GFR. Hence, objective evaluation of venous congestion is now gaining a lot of attention. Point-of-care Doppler ultrasound is emerging as a valuable bedside tool to assess venous congestion. It's a common myth that IVC ultrasound is easy to perform and it can give us all information about the patient's volume status, while the fact is that volume assessment is complex and there are many pitfalls associated with isolated use of IVC diameter. We now follow the pump, pipe, and the leak approach for volume assessment, where pump refers to forward arterial flow, pipes to venous outflow, and leaks is indicated by tissue congestion. So there are three POCUS strategies to assess congestion. Pumps represent focused cardiac ultrasound, pipes include IVC ultrasound and VEXUS, leaks is indicated by lung ultrasound. So POCUS-assisted hemodynamic assessment is no longer just about the IVC ultrasound, but involves assessment of the other modalities as well. So let's begin with the IVC ultrasound. Longitudinal view of IVC is obtained by placing the curvilinear probe in the subxiphoid window. The IVC diameter is measured perpendicular to the vessel, about 2 cm away from the hepatic vein confluence with the IVC. Its size and collapsibility are considered as good surrogates for right atrial pressure. This picture shows the typical respiratory variations of IVC diameter, where we can see the inspiratory collapse. When this variation is abolished, it would mean that the right atrial pressure is high and the patient is unlikely to be fluid responsive. Though the IVC serves as a good surrogate for venous congestion, there are still many factors which influence its size and collapsibility. For example, the magnitude of the patient's respiratory effort, technical factors like obesity, increased intra-abdominal pressure, and there are problems inherent to using the conventional long-axis view of the IVC. This is because IVC is a three-dimensional structure with an elliptical shape, and studies have shown that it is better to evaluate its diameter in both the short axis and the long axis view. So for IVC ultrasound, one view is definitely no view. So owing to these pitfalls, there is a need to look beyond the IVC ultrasound for volume assessment. And here comes the role of VEXUS, which is a protocolized venous Doppler examination, where we first perform the IVC ultrasound, and if it's more than 2 cm, we proceed with sequential Doppler assessment of the hepatic vein, portal vein, and the intrarenal vein. So how to look for the hepatic vein Doppler? We get a 2D image of the hepatic vein draining into the IVC by placing the curvilinear probe in the anterior right upper quadrant over the liver. After activating the PW Doppler mode over the hepatic vein, we can get the tracing. So for time constraints, I'm not getting into the details of these waveforms, but normally we get to see the ASVD pattern. In the normal setting, we can see that the S wave is deeper than the D wave, but with increasing right atrial pressure, the S wave becomes progressively shorter, and with severe congestion, there's a complete reversal of the S wave. Regarding portal vein Doppler, so here we can get a 2D view of the portal vein by placing the probe in the lower right midaxillary line, and after activating the PW Doppler mode, we get the continuous waveform, but in the setting of elevated right atrial pressure, the portal vein starts to demonstrate pulsatility. So with severe congestion, there's a more than 50% pulsatility in these waveforms. Intrarenal venous flow exploration. This is a difficult Doppler assessment to perform as the veins are smaller and patients' breath holding capacity can actually limit our views. So in the normal setting, if we look at the bottom part of the tracing, it is a continuous waveform but with increasing congestion. So these waveforms becomes discontinuous and demonstrating only the systolic or the diastolic phase. So after assessing the Doppler waveforms, we now use the VEXAS scoring to grade patients based on the severity of congestion. Grade 3 severe congestion, for example, means the IVC diameter is more than 2 centimeter with at least 2 severely abnormal Doppler waveforms. So what is the relevance of this scoring system for us nephrologists? This is a landmark paper based on which the VEXAS grading system was developed, and here the authors found that severe venous congestion showed the strongest association with the development of subsequent AKI in patients undergoing cardiac surgery. So the authors also compared the performance of the VEXAS score with isolated CVP measurement, and they found that the post-test probability of having an AKI with a high VEXAS score was significantly higher compared to using CVP measurement alone. A therapeutic dilemma that is often faced by us is when to give and when to stop fluids. VEXAS does not give us much information on the need for fluids, but it tells us important stop points for fluid resuscitation. It reflects real-time changes in hemodynamics, and it can be used to guide decongestive therapy. So this was a case report published in KI where we can see the transition in the hepatic vein and the portal venous waveforms in a dialysis patient from day 0 to day 8 with progressive ultrafiltration indicating improvement in venous congestion. But these Doppler assessments are not without important caveats. Portal vein, for example, can show false pulsatility in thin, healthy subjects. Intrarenal venous Doppler, as I mentioned, can be technically challenging. So the key point here is it is better to avoid interpreting any of these exams in isolation. They should always be interpreted in toto for a meaningful conclusion. Pumps in POCUS hemodynamics is represented by cardiac ultrasound. Focused cardiac ultrasound is now an important component of POCUS hemodynamics, and with a short basic training, we can quickly answer some important questions at the bedside like, does my dialysis patient with unexplained hypotension have pericardial effusion? How is his LV systolic function, RV size and function? With additional training in Doppler modalities called advanced cardiac ultrasound, we can evaluate other parameters like stroke volume and LV filling pressure. The 5 most commonly used views in POCUS are the parasternal long axis, short axis, apical 4-chamber, subcostal 4-chamber, and the subcostal IVC view. So we have to remember that for all cardiac applications, the orientation marker is on the right side of the screen. The parasternal long axis view, we orient the beam with the long axis of the left ventricle, and here we can examine the pericardial space, look for the RV size, LV size, and watch for their contractility. In the parasternal short axis view, we orient the beam perpendicular to the long axis of the left ventricle. There are 3 levels of the parasternal short axis view. This is the mid-papillary view, and with this view, we can look for global LV function and watch for regional wall motion abnormalities. The apical 4-chamber view is obtained by placing the transducer at the point of maximum apical impulse, and here we can do Doppler assessment of the mitral and the tricuspid valves, and this is also the most informative view to look for global RV function. The subcostal or subxiphoid view is done in emergency situations when we cannot obtain a good parasternal view like while performing a CPR. So we basically look at 5 F's in a focused echo. These F's stand for fluid, form, flow, filling, and function. So we'll begin with fluid. Asymptomatic pericardial effusion is prevalent in nearly 62% of ESRD patients, with nearly 10 to 20% of them going for a cardiac tamponade. A high index of suspicion is required as CKD patients may not present with the classic findings of the Beck's triad. So focus performed by non-cardiologists can diagnose pericardial effusion and tamponade with 95% accuracy compared with conventional echo. This is a parasternal short axis view of one of our dialysis patients who was severely volume overloaded and had frequent episodes of intradialytic hypo. Here we can see the anechoic space around the heart. It measured around 3.3 centimeter, signifying large pericardial effusion. So the next step stands for function. Qualitative assessment of LV systolic function is sufficient for focus, and this is done by looking at how well the LV wall is moving and how well the anterior mitral leaflet is moving. To say normal ejection fraction, the LV walls should come close together during systole, and the anterior mitral leaflet should almost touch the septum during diastole. So this is a apical 4-chamber view of one of our patients, where we can see that the LV wall is barely moving and the anterior mitral leaflet doesn't touch the septum, signifying a global LV dysfunction. So the third F stands for form, where we look at the relative chamber size. So the RV walls are normally thinner than the LV, and the RV chamber is approximately 2/3 of the LV cavity. This is best seen in the apical 4-chamber and the parasternal short axis view. But with progressive RV pressure overload or volume overload, we can see flattening of the interventricular septum, leading to a D-shaped LV. Leaks in POCUS hemodynamics is represented by lung ultrasound. So knowledge of lung POCUS can help us to narrow down the differential diagnosis and ascertain the cause of breathlessness in patients presenting to the ER. It's important to remember that the normal lung tissue is not seen in ultrasound unless it's consolidated or atelectatic. Sonography of lung is performed by placing the curvilinear or the phased array probe perpendicular to the chest wall. To ensure that we have placed the probe correctly, we look for the bat wing sign, which is a characteristic appearance of the pleural line and the two adjacent ribs. So lung ultrasound is all about artifacts. The A lines are horizontal reverberation artifacts, and presence of A lines indicate healthy aerated lung. B lines, on the other hand, are vertical reverberation artifacts which originate from the water-thickened interlobular septa. So B lines basically represent the shape of lung water, and the number of B lines increases proportionately to the degree of pulmonary congestion. The zones of sonar auscultation. So we were formerly performing the 28-zone lung scanning technique, but this is cumbersome to use and it was inconvenient for patients, and this is now largely reserved for research purposes. So to save time, we have now resorted to the abbreviated lung scanning protocols. We use the 4-zone or the 8-zone technique. So which of this technique to choose? Studies have shown that the 8-zone technique correlates well with the classic 28-zone technique and retains its prognostic significance. So in short, for acutely dyspneic patients, less number of zones can be examined to come to a quick conclusion. For chronically volume overloaded patients, more zones need to be examined. Presence of more than or equal to 3 B lines in one intercostal space is abnormal, and it's called the B pattern. If we see the B pattern in at least 2 lung zones bilaterally, then it indicates the presence of interstitial syndrome. B lines does not always mean pulmonary edema. It can also be seen in parenchymal lung disease like fibrosis or interstitial pneumonia. If we happen to see irregular fragmented pleural lines or non-homogeneous distribution of B lines, then this is more in favor of fibrosis rather than a pulmonary edema. So this was our original research article from the Department of Nephrology, Government Stanley Hospital, where we looked at the role of lung ultrasound to assess dry weight in maintenance HT patients. Here we compared the performance of lung ultrasound with HRCT and with IVC diameter. So we found that the classic conventional physical signs like edema, crackles, and dyspnea had a poor sensitivity to detect pulmonary congestion by lung ultrasound. Asymptomatic pulmonary congestion was prevalent in nearly 50% of our dialysis patients, and the B lines showed a good correlation with HRCT signs of pulmonary congestion. Identifying pleural effusion is another important component of nephro-POCUS. Pleural effusion and consolidation are best assessed at the Plapp's point, which is obtained at the intersection of the posterior axillary line and the rib space between the 10th and the 12th ribs. So to summarize, multi-organ POCUS performed by nephrologists can help us to define 2 hemodynamic phenotypes. In the underfill phenotype, we get to see A lines in lung ultrasound, which is normal. Focused cardiac ultrasound shows a hyperdynamic LV with the RV cavity less than 2/3 of the LV. These patients demonstrate a small collapsible IVC. Vexus scanning is not required for them as the IVC is small. In the overfill phenotype, we see B lines or pleural effusion. Focused cardiac ultrasound shows decreased LV systolic function if systolic heart failure is the etiology of the overfill. RV volume overload is indicated by a dilated RV and D-shaped LV. So these patients demonstrate a plethoric IVC, and we can proceed with Vexus scanning. So there are studies to show that there is a significant role for POCUS in the management of patients with hyponatremia because it can help us to differentiate between the hypervolemic and the hypovolemic phenotype. So I'll conclude with briefly discussing a case scenario where POCUS guided our management. Our patient was a 55-year-old lady, hypertensive and diabetic on maintenance HT. So she crash landed at the ER on 2 occasions with acute pulmonary edema in a span of 1 week. She denied any chest pain, palpitation, syncope. On clinical examination, there was no pedal edema, but she had bilateral Krebs on auscultation. She was only 0.5 kilo above her usual dry weight of 39. So we proceeded with POCUS hemodynamic assessment to look for the cause of recurrent pulmonary edema and to reassess her dry weight. Her IVC diameter was around 2 centimeter. The hepatic vein and the IVC confluence was plethoric, and this resembled the moose head, which is seen in heart failure. So we performed VEXA scanning for the patient and found that the waveforms were suggestive of mild congestion. Her lung ultrasound, on the other hand, showed multiple extensive confluent B lines, and this was disproportionate to the degree of pedal edema or other peripheral signs of fluid overload. So we quickly performed a focused cardiac ultrasound at the bedside, and these findings were not noted in our previous recent echo. So in the 4-chamber view, she had a dilated left atrium, left ventricle, and if you could see at the arrowhead, there is a significant regional wall motion abnormality of the mid-septum, signifying a CAD of the LAD territory. So consolidating these findings, we made a final diagnosis of an acute left ventricular failure, which is precipitated by an ACS of the LAD territory. So we performed SLED and gentle ultrafiltration for the patient, and then she was referred to the cardiologist. Her TROP-T and NT-proBNP levels were also elevated. So her angiogram showed proximal LAD lesion with 90% stenosis, and she underwent a PCI to the LAD. So what if focused cardiac ultrasound was not performed early? Aggressive ultrafiltration and the associated drop in blood pressure could have compromised a coronary perfusion pressure further, leading to worsening ischemia and heart failure symptoms. So to conclude, POCUS allows visualization of the anatomy in real time and helps us in confident decision making. But the additional information provided by POCUS is futile if it's not interpreted in the clinical context. It is emerging as a non-invasive bedside tool that gives us good insight into the cardiovascular physiology and hemodynamics of fluid status. Attaining competency in POCUS, however, is a gradual process, and future research should focus on studying the effects of POCUS-guided care on patient outcomes. So thank you for your patient listening.
Thanks, Dr. Aishwarya, for that very crisp and simple presentation. The issue with POCUS is actually, it's a very healthy proposition to look at the ultrasound with respect to the issue when a patient comes to the AKI or volume overload. The issue with POCUS is the expertise. So we nephrologists are not doing ultrasound regularly. So the issue is actually the expertise. The skill has to be acquired over a period of time. So thinking from the broader perspective, probably the POCUS has to be incorporated into the various training programs, various nephrology curriculums, because the Doppler findings it is not very easy to master the Doppler. So grayscale is still okay. You can just keep a probe. As a nephrologist, I can say if there is H1 or not. Is a bladder dilated? Is a bladder full or not? Is a catheter obstructed or not? We can probably look at the IJC and then put the line. Biopsy can be guided. But beyond that, POCUS needs a rigorous training to know exactly what is happening. So that is probably the challenge which is ahead of us, which need to be addressed. So probably POCUS has to be incorporated. It's a very healthy proposition. It's an adjunct to physical examination. It actually dissolves this fragmentation of care. The diagnosis can be made easy, and the management can be expedited. So the challenge remains in probably popularizing POCUS to have a robust training program so that the trainees are well trained, so that the interpretation is much better. So that is what I would like to add here. Yeah, Doctor.
Yeah, thank you, Dr. Aishwarya. That was an excellent presentation. Pumps, pipes, and leaks, obviously. I mean, this is one which we have been learning over the last few years. So adding to Dr. Nayar's comment that it needs to be included, it should be made mandatory. Otherwise, it will, like the way we have taken over from the interventional radiology with respect to all the procedures, interventional nephrology, I think the POCUS has to be included in the curriculum so that it becomes a regular norm. Any comments from the floor? So I would also like to take this opportunity to mention that Dr. Abhilash Koratala is visiting Hyderabad and teaching us on the POCUS aspect as a hands-on workshop along with Dr. Girish Reddy in the second week of March. So we will be releasing the flyer. I think people who are interested can join. Any comments from the floor apart from this? If there are no comments, yeah, Dr. Raji.
Thank you so much, Dr. Manjusha.
The first day we had a POCUS training, the pre-conference day. Yeah.
Dr. Manjusha and Dr. Rajesh R. Nair.
Thank you so much.
Thank you very much. Thank you.
Can you please honor Dr. Aishwarya Annamalai with the memento? I request Dr. Ramachandran to honor our chairpersons.